Hello, my name is Ravi Vij. I'm from My Cancer Haven, and in our conversation with Cancer Expert series today, we are fortunate to have Dr. Bita Fakhri from the Stanford University School of Medicine to talk to us today about frontline treatment for chronic lymphocytic leukemia. She's a rising star in the CLL world, and we are honored to have her today. Welcome, Bita.
Pleasure to be here, Dr. Vij.
So, Bita, so can you give us an overview of what are the treatments that you have to choose from? You're getting more and more treatments into frontline CLL now.
Yeah, thank you for the opportunity. I always tell patients there is never a good time to get CLL, but there is no better time than 2024, just because we have a menu of treatment options available. As shown in this slide, we have the old chemotherapy options, alkylators such as cyclophosphamide, bendamustine, and we'll review the data, fludarabine. We have the CD20 monoclonal antibodies, which have been available in the field for the past 2+ decades, rituximab, and more recently, obinutuzumab, and the emerging data from obinutuzumab. We have the B-cell receptor pathway inhibitors, particularly BTK inhibitors, which have become very prevalent in the treatment of CLL. And now we know we have covalent BTK inhibitors, which bond a covalent bond with the CYS481 site of the Bruton tyrosine kinase enzyme. First one, which got approved for CLL 10+ years ago in February 2014, ibrutinib, followed by newer generation drugs, acalabrutinib and zanubrutinib. And more recently, on December 1st, 2023, we got the approval for non-covalent BTK inhibitor, pirtobrutinib, for patients with double refractory CLL. And double refractory are patients who have seen and failed a covalent BTK inhibitor in the past, and also a BCL2 inhibitor. The beauty of non-covalent BTK inhibitors, as you know, once you continue a covalent BTK inhibitor for a while, resistance mutations are inevitable. And the non-covalent BTK inhibitors, they're more liberal in their action. They bind, unbind, rebind, so they don't necessarily require that strict shape of the receptor to exert their function. Pirtobrutinib and nemtabrutinib is now currently in the clinical trials. PI3 kinase inhibitors belong to the B-cell receptor pathway, particularly duvelisib and idelalisib. In terms of efficacy, very good drugs, but associated with high rates of toxicity, autoimmune hepatitis, pneumonitis, and conditions that makes tolerance difficult. And, what good is a drug if a patient is not able to tolerate it? And then we also have BCL2 inhibitors, with venetoclax being the first that is currently approved. And there are also some that are currently being investigated in clinical trials, particularly sonrotoclax, which we'll get to it later. It is actually being investigated in a phase 3 clinical trial. So as you see, with the chemoimmunotherapy, with BTK inhibitors, BCL2 inhibitors, PI3 kinase inhibitors, the field is just expanding day after day.
So how do you approach frontline CLL treatment? I have heard that this is the cancer that made chemotherapy history. So is that true? Is there a role for chemoimmunotherapy today?
That is the beauty of CLL, which is the very first leukemia that left chemoimmunotherapy behind. And just a little to put things into historic perspective, in the first decade of the 21st century, when rituximab was introduced to the field of B-cell lymphoproliferative disorders, you see the Kaplan-Meier curve, as showed on the left side, where rituximab was added to the backbone regimen of what we were already using for a variety of B-cell lymphomas. For example, in diffuse large B-cell lymphoma, if you look at CHOP versus R-CHOP, you see a prominent difference when rituximab was added to the backbone chemotherapy. Same for CLL, when the German CLL study groups conducted the CLL-8 trial, where rituximab was added to fludarabine cyclophosphamide, which is known to be a very lymphodepleting chemotherapy regimen. As a matter of fact, nowadays, fludarabine and cyclophosphamide is one of the regimens that you're using for lymphodepleting chemotherapy prior to CAR T-cell therapy. And here you see that FCR, without any question, was a winner compared to FC. But then, who are the CLL patients? Our patients with CLL, they have a median age of 67 to 72 years of age with multiple comorbidities, not really good kidneys. So FCR is a regimen that for the most part can be tolerated by young and fit patients, not the reality of what we see in a CLL patient. So the CLL-10 trial was an effort, it was a non-inferiority trial to basically compare FCR to bendamustine rituximab. Not only FCR, not only BR was not inferior to FCR, but it was also associated with better tolerability in terms of second primary malignancies and also rates of infection. So based on the CLL-8 and CLL-10 trial, FCR became the standard of care for young and fit CLL patients at that time. And we've all seen patients in their 20s getting CLL. And BR became the standard of care for old and frail patients with CLL. But this is when chemoimmunotherapy was globally acceptable until BTK inhibitors came into play, which we'll discuss in the future slides.
Yeah, so that's a good, segue into BTK inhibitors. We have now having a large number of these compounds in practice. So can you tell us a little bit about the three first and second generation
Yeah,
inhibitors?
definitely. So ibrutinib, if someone asked me what was the most influential, basically, drug in B-cell lymphoproliferative disorders in the first decade of the 21st century, my answer is rituximab. If someone asks the very same question in the second decade of the 21st century, the answer is ibrutinib, without any question. It truly transformed the field of B-cell lymphoproliferative disorders, particularly CLL. So I know it has fallen out of favor more recently because of the side effect profile, but it's important to honor the molecule for the contributions to the field. So here you see the kinome map of three currently FDA-approved BTK inhibitors, covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib. And the circles basically represent off-target inhibition, targets other than BTK, and the radius of each circle represents the strength. So you see that just visually looking at the kinome maps, acalabrutinib has the cleanest kinome map compared to ibrutinib. So ibrutinib was the first one which was approved, but we know that has a cardiovascular side effect profile that makes tolerance challenging for old and frail patients. And that's when acalabrutinib and zanubrutinib, other covalent BTK inhibitors with the very same mechanism of action, came into play. And we will discuss the registration trials for each of these agents in future slides.
Okay, so let's start with ibrutinib.
Yeah, the Alliance and ECOG trials were two landmark phase 3 trials. Just to give a big picture, the Alliance trial decided, okay, now we have this covalent BTK inhibitor that has been investigated against not so good agents in early trials, ofatumumab and chlorambucil. If we have confidence in this molecule, let's bring it forward and compare it to real chemoimmunotherapy. And that was the thinking behind the Alliance phase 3 clinical trial design, where they investigated ibrutinib, a single agent, or combined with rituximab versus bendamustine rituximab in old and frail patient population with CLL. And here you see that both ibrutinib containing arms were far superior in terms of PFS as compared to bendamustine rituximab, which up until that point, based on CLL-10 trial, was thought to be the gold standard for old and frail patients. So you see the hazard ratio for ibrutinib versus BR in both arms, regardless of rituximab combination, was 0.36, meaning 64% reduction in progression in ibrutinib containing arms. And if you look at, because we are always constantly trying to answer whether adding the CD20 monoclonal antibody is going to do our patients any service. And here you see that there was no difference between the ibrutinib containing arms. So based on the Alliance phase 3 trial, ibrutinib, either combined with rituximab or as single agent, became the standard of care for patients with CLL who are old and frail. Parallel to the Alliance trial, the ECOG group They started the phase 3 trial of ibrutinib plus rituximab versus fludarabine cyclophosphamide rituximab in young and fit patients with CLL. And as we discussed, based on CLL, the CLL-8 trial, FCR, up until this point, was the gold standard for patients with CLL who were young and fit. So here you see that ibrutinib rituximab in terms of PFS was far superior to FCR. And they also answered the question because there was still some thinking that FCR does as well as ibrutinib in patients with mutated IGHV who are have the most favorable risk feature. But here you see that the subset analysis based on IGHV mutation status, yes, the difference between ibrutinib, rituximab, and FCR is more prominent in the unmutated IGHV patients. But even in patients with mutated IGHV, ibrutinib plus rituximab in terms of PFS was still superior to FCR, as evidenced by the 5-year PFS of 85%, close to 85% versus 70% in patients with mutated IGHV. So based on this really elegantly done clinical trial, ibrutinib also became the standard of care in patients with CLL who are young and fit, regardless of risk features in America. And the FLAIR study also investigated the very same concept, which was shown on the right side of the previous slide.
So what about acalabrutinib then?
Yeah, so if you look at both ECOG and Alliance trials, which we discussed, the cardiovascular side effect profile with ibrutinib, particularly cardiac dysrhythmias, including sudden cardiac death, was a problem. So the next rational step is to investigate the new generation covalent BTK inhibitors that have a cleaner kinome map and are thought to be better tolerated compared to ibrutinib. And that's where the Elevate TN comes into play, Elevate for treatment naive, because the trial also had one RR for relapsed refractory patients, but my focus is Elevate in treatment naive patients. And the trial had 3 arms. It randomized patients with treatment naive CLL who were above the age of 65 or young, but not suitable for intense chemoimmunotherapy and not so good. They're old and frail. They have a creatinine clearance 30 to 70 and they're young, so they're not expected to have bad kidneys, or they have a cumulative illness rating score of greater than 6, meaning they have multiple comorbidities. So it randomized either old patients or young and frail patients to either receive acalabrutinib plus obinutuzumab, shown in blue, versus single agent acalabrutinib, shown in orange or red, whatever color you see that, and obinutuzumab chlorambucil, shown in green. And here you see the 5-year progression-free survival was 84% in the obinutuzumab acalabrutinib arm versus 72% in the acalabrutinib single-agent arm, and versus 20% in the obinutuzumab chlorambucil. So you see both acalabrutinib containing arms did much better than obinutuzumab chlorambucil, which is not a surprise, but they did pretty well. It is important to say, I don't know, when you really don't know something. And I have talked about this issue with multiple CLL investigators. Here you see that the obinutuzumab plus acalabrutinib arm, there is a 12% difference at 5-year PFS between obinutuzumab chlorambucil versus, obinutuzumab acalabrutinib versus single agent acalabrutinib. And I really don't have any, rational explanation for that. I don't buy the fact that someone got 6 doses of rituximab, obinutuzumab monthly in the beginning of their treatment, and 5 years later, there is still a 12% difference. So I don't think anyone has any convincing explanation what happened here. But the bottom line is both acalabrutinib containing arms did pretty well. And then the question is, what are the subset of patients who actually benefited from adding obinutuzumab? And that's the question that we are answering in the right-sided curve. Here you see that the question was, who are the patients that are benefiting? Is it patients with bad prognostic features, particularly patients with TP53 aberrant disease? And if you look at the curve, you'll see that there was actually no difference in terms of PFS in either of the acalabrutinib containing arms, regardless of adding obinutuzumab. So both arms in patients with TP53 aberrant disease did very similarly. So this thinking that maybe patients with bad risk features are the ones who are benefiting from adding a CD20 monoclonal antibody, that theory was debunked by the curve on the right side of this slide. But regardless, acalabrutinib, based on the ELEVATE-TN trial, became a standard of care agent with 5-year PFS of 70 to 85%, which is a very good place to be.
And obviously, the most recent entrant has been zanubrutinib. What can you tell us about its registrational trials?
Yeah, so the registrational trial for zanubrutinib was the Sequoia trial. Again, very elegantly designed. The two cohorts that I'm going to talk about. So the cohort 1 included patients without TP53 aberrant disease, which is the moral and ethical thing to do because we know those patients do very poorly with chemoimmunotherapy. And as a matter of fact, giving chemotherapy enriches the bad features down the road. So their disease will come back more aggressively because we killed the good CLL cells and we just enriched the ones that harbored TP53 mutation or 17p deletion. So the cohort 1 included patients who did not have 17p deletion and or TP53 mutation. And you see that the 42-month PFS was 82% with Zanu as compared to 50% with bendamustine rituximab. And then they have the cohort 2 specifically designed for patients with 17p deletion and or TP53 mutation. And here you see that 3.5 years, 80% of those patients are still in remission. You know, basically 3.5-year PFS for patients on single agent zanubrutinib with 17p deletion and or TP53 mutation is close to 80%, which is a very good place to be for patients with high risk features. Based on the Sequoia trial, zanubrutinib became the standard of care, one of the standard of care options in the frontline setting for patients with CLL.
So what about the other drug class, the BCL2 inhibitors? What can you tell us about where they stand today and the trials that led to their approval?
Yeah, so in terms of BCL2 inhibitors, the German CLL study group did a very important study. They randomized patients with untreated CLL, and they really did not cherry pick patients. They picked patients with coexisting medical conditions with a cumulative illness rating score of greater than 6. So these are patients who have comorbidities and or they are not coming in with the best kidneys. Their creatinine clearance, it allowed patients with creatinine clearance of less than 70 to get enrolled on the trial. This is very much representative on the real world population of CLL patients. So those patients, and up until this point, this trial was designed for old and frail patients with CLL. We know that based on CLL 11 trial, obinutuzumab chlorambucil became a standard of care for old and frail patients. We did not show that, but this trial was an effort to come up with a combination that could beat the obinutuzumab chlorambucil for old and frail patients with CLL. So how the trial was conducted, patients were started on obinutuzumab for the first cycle. They got it on days 1 and 2, split dosing, day 8, day 15, and then venetoclax ramp up was started on day 22 in a 5-week ramp up fashion. And patients were continued on obinutuzumab cycles 2 to cycle 6 monthly, and they were continued on venetoclax until the end of cycle 12, day 28. And obinutuzumab chlorambucil was administered obinutuzumab in the same fashion, chlorambucil every other week for a total of 12 cycles. And here you see that the primary endpoint was investigator-assessed PFS. So the trial presented the 6-year follow-up data, and here you see that the 6-year PFS was 53%. I always pause and make sure my patients understand this endpoint. So this means that in patients who took treatment for 1 year, as shown here by the stop sign, they enjoyed a 5-year treatment-free remission And then at the end of 6 years from the beginning of treatment, 5.5 out of 10 patients are still enjoying a remission. And what we are not showing here is the 6-year time to next therapy, which is a very valid endpoint in a chronic leukemia like CLL. If you look at the 6-year time to next therapy, 65%, meaning only 3.5 out of 10 patients have moved forward to start a new line of therapy. And on the right side, you see beautiful overall survival for both arms, which speaks to the fact that even for patients with chlorambucil obinutuzumab, when they progress, they had access to incredibly effective and tolerable treatment options so that their survival does not get affected. And based on the CLL14 trial in 2019, time-limited therapy with venetoclax for a total of 1 year and roughly 6 monthly infusions of obinutuzumab, with the exception of the first cycle, became the standard of care for patients with CLL who have never been treated before.
So how do you choose between these agents now?
I always tell patients there is no right or wrong answer. It is very important not to put these drugs in war against each other. Sadly, and unfortunately, there is a market war going on, but there is a right patient for every treatment option. And a lot of it is just mutual conversations with patients. So BTK inhibitors in general, some people find it very convenient to take a pill with no infusions, not having to come in and get your labs checked and be frequently monitored for tumor lysis syndrome throughout the 5-week ramp up of venetoclax. There is, the first covalent BTK inhibitor got approved 10 plus years ago. So there is long-term efficacy data. And we know we have reliable data in patients who progress on BTK inhibitors and move on to venetoclax. They still have durable responses to venetoclax after having failed a covalent BTK inhibitor. And we also discussed the phase 3 data comparing FCR and BR with ibrutinib-containing agents and other covalent BTK inhibitors. With venetoclax or obinutuzumab, some people really cannot wrap their head around being on a cancer-related therapy their whole lives. So the time-limited therapy is a very appealing factor for a good number of people. And, unlike covalent BTK inhibitors, there is no cardiovascular side effect profile associated with venetoclax and no bleeding risk. And we know, we have a patient who develops AFib, they get on a DOAC, oral anticoagulant therapy associated with a higher risk of bleeding, and combine that with a drug. Covalent BTK inhibitors inherently are also associated with a risk of bleeding. So everyone is a little anxious to make sure that nothing major or catastrophic happens. So there is no known cardiac or bleeding risks or long-term complications such as hypertension. And, nobody likes to be on a covalent BTK inhibitor, develop hard to control hypertension, which is a late side effect happening 2 years into treatment. And then they have to get on 2 to 3 antihypertensives to treat their hypertension caused by their cancer-directed therapy. So the polypharmacy associated with that for life is not appealing for patients. And then, if you have 1 year of treatment, you're more reassured that patients are motivated to adhere to their treatment. And also the financial toxicity associated with long-term therapy as compared to time-limited therapy on both patients and payer is something to take into consideration. And, currently there is a phase 3 trial comparing obinutuzumab venetoclax with zanubrutinib plus the new BTK inhibitor, the new BCL2 inhibitor sonrotoclax. So there are phase 3 trials trying to compare obinutuzumab venetoclax with other agents that are out there. So again, you see, it really depends on what kind of person you are as a patient. And I always present the data as I try to be as unbiased as possible. But that being said, I am unapologetically biased toward time-limited therapy. But if someone has TP53 aberrant disease, I pause and I certainly discuss BTK inhibitors with that patient population. So the bottom line is there is no right or wrong answer. It's just knowing the data, metabolizing the data, and finding out what feels right to you as a patient.
So, and do you have a preference for the really old and really frail?
So the CLL14 trial included really frail patients. And the median age was 72, which is not old. I think 72 to me is honestly, I cautiously call it young, at least, particularly for a patient with CLL. But if a patient, if you're talking about a 90-year-old, I certainly do not want to inconvenience them to come and get the infusions and be admitted to the hospital and be observed for, TLS, tumor lysis syndrome management. So I think for those patients, covalent BTK inhibitors is the way to go.
So how big is this issue of TLS? Is it something that we've been able to overcome, or is it still more than a nuisance?
You know, it's I'm really glad you asked that question because with the CLL14 trial, with venetoclax, the risk of TLS has been blown out of proportion, to be honest with you. If you look at the data, and double check me on the numbers, but I think in each arm of CLL14 trial, 216 patients were enrolled. And in the venetoclax or obinutuzumab arm, 3 out of 216. So less than basically about 1% of patients developed TLS, and they developed lab TLS. They did not meet the clinical criteria for TLS. So I think the way the trial was designed and conducted to give obinutuzumab in the beginning for 3 doses before introducing venetoclax in a very gradual ramp-up fashion really eradicated that possibility of developing really bad tumor lysis syndrome. So yes, cytopenias with venetoclax are real. Yes, changes in bowel habits and GI symptoms are real, but I really think the TLS risk has been blown out of proportion. Data speaks for itself. 1% TLS risk, similar between both obinutuzumab chlorambucil and obinutuzumab venetoclax, is not something to lose sleep over. That being said, when I talk to my community providers, we have the luxury of practicing at academic centers. There is a village of nurses and, advanced practice providers that support us. Yes, you need to check in with patients initially on a weekly basis. And when I'm talking to patients and they're worried about infusions and frequent lab draws, I always tell them, don't choose to be myopic. It's a difficult 2 months, but then with cycle 3 moving forward, they really find their rhythm. And at 1 year, they're done and they enjoy a prolonged treatment-free remission, even in the presence of high-risk features, including unmutated IGHV and including TP53 mutation or 17p deletion. What was not shown, if I may just talk about that, in the subset analysis, small numbers, I acknowledge that. But for unmutated IGHV, the median PFS with obinutuzumab venetoclax is 65 months, which is good. It means 1 year of treatment, basically 4 years of treatment-free remission, and then at 5 years, your disease comes back, and then you respond to whatever agent you choose to proceed with. And in TP53 aberrant disease, again, small numbers, but the median PFS was 52 months, which is good enough in the eyes of some providers and some patients. Some providers strongly believe we need to do better for those patients, but that means 1 year of treatment, 3 years of treatment-free remission, and then your disease comes back. And in the majority of cases, because of time-limited therapy, the patients have not developed resistance mutations to venetoclax. So they even have the option of being retreated with venetoclax, which is a more, elaborate conversation. But back to your question, I hope because of this tumor lysis risk, we do not deprive patients of this treatment strategy.
So I guess soon it may not be a choice between the two. It may be combination therapy. You and your colleagues are doing a number of trials looking at this, and the Captivate is one of many trials ongoing. So, what can you first of all tell us about the Captivate study, and then generally what your take on combination therapy is and the data as it stands?
Yeah, Captivate was a very important trial in terms of investigating this concept, being the pioneer in investigating this concept, along with some other trials like GLOW in Europe. So, what Captivate did was the future of clinical trial design for CLL is MRD guided duration of therapy, and combining BTK inhibitors and BCL2 inhibitors with the hope that we can provide all patients with time limited therapy. So Captivate, how it was designed as shown in this slide, patients took 3 cycles of ibrutinib to debulk their disease, and then they took 12 cycles of combination ibrutinib and venetoclax, and at the end of cycle 15, patients got checked for MRD. So here it says undetectable MRD, and I don't want to complicate things, but this is confirmed UMRD, or confirmed undetectable measurable residual disease. And it's different from undetectable MRD because confirmed UMRD required 2 MRD analyses in the marrow for 3 months apart on 2 consecutive, basically, samples. And some patients, we know they don't want to undergo a lot of bone marrow biopsies, or they didn't get to do this because of COVID. But undetectable MRD, there were some patients with undetectable MRD whose UMRD status was not confirmed. In any event, to simplify it, at the end of cycle 15, they got checked for MRD, and if they had confirmed UMRD, they got randomized to either receive placebo, which is, if you look at it, it's time-limited therapy. They got 15 months of treatment, and then they didn't get anything, or continue on ibrutinib. And in the patients who had detectable MRD, they were randomized to ibrutinib versus ibrutinib plus venetoclax, because we are trying to see if continuous doublet therapy is going to provide these patients with any added benefit. Lots of nuances to this trial, but the primary endpoint was 1-year disease-free survival in patients with confirmed UMRD in the MRD cohort, and the CR rate. And if you go to the next slide, you see that 56% of patients achieved CR, and the 2-year PFS rate in all comers was 95%. In patients without deletion 17p was 96%. These are really high numbers that we are talking about. And even, at 2 years, in patients with 17p deletion or TP53 mutated disease patients, the 2-year PFS was 84%. The question is, and this is time-limited therapy, and more than 9 out of 10 patients finished the study treatment. And if you look at the MRD status in peripheral blood and bone marrow, one would hope that they overlap better, so that patients should not, do not have to undergo bone marrow biopsy for MRD analysis. But sadly, that's not the case. So the UMRD percentage in patients without deletion 17p was 76 and 62% in blood and marrow. In patients with deletion 17p was close to 40%. So we know at some point their disease will come back, but at least 40% of patients with this approach, with doublet therapy, achieved UMRD. And in all treated patients, regardless of their TP53 deletion mutation status, it was 77% and 60% in blood and marrow. So I think Captivate is a very important study in terms of introducing doublet therapy. They have done many sophisticated analysis showing that time-limited therapy prevents development of resistance mutations. So even in patients whose disease come back, they got on a covalent BTK inhibitor or venetoclax, and they still had very good responses. Because if you are not continuously on a treatment, the likelihood of developing resistance mutations are far lower as compared to someone who's continuously on treatment. I think this question of doublet, time-limited doublet versus obinutuzumab venetoclax, because the major question is, did adding a BTK inhibitor to BCL2 inhibitor actually help these patients at all? That question is currently being investigated in a phase 3 trial comparing obinutuzumab venetoclax to zanubrutinib, which is a covalent BTK inhibitor, combined with sonrotoclax, which is a new BCL2 inhibitor. And we can all have our feelings about what we want to believe, but I think trial will speak for itself. And hopefully this question will be adequately, confidently, and definitively answered after that trial reads out, which the trial did phenomenal. The trial was supposed to be open for another 2 years, but by the end of December 2024, we heard that they're going to meet their accrual goals. So we are going to have results in the next few years.
So I guess where do you see the field 5 years from now? I think we've talked about how you choose the frontline agents based on various factors. So it would be nice to get your take on where the field is moving in frontline therapy.
I think in frontline therapy, as discussed, the main question is time-limited therapy. There is a focus on time-limited therapy. MRD is an evolving topic in CLL, and I highly encourage my community colleagues to not basically base treatment decisions on MRD at this time and age, because I see some of my colleagues who continue venetoclax. They start someone on obinutuzumab venetoclax based on CLL14 trial. They check MRD at the end of 1 year. If they're still MRD positive, they continue venetoclax. That is a data-free zone. I know, sometimes I feel like we're doing that to treat ourselves rather than treat patients. And if you what we didn't show, the 6-year follow-up of the CLL14 trial, the 6-year UMRD is 7%, but the 6-year PFS is 53%. So 5.5 out of 10 patients have not had clinical progression, but 93% have become MRD positive. So in CLL, MRD positivity does not immediately translate into disease progression. And that's where we really need to hold our horses until more data becomes available. Also, if we solely use MRD to guide treatment duration, I'm afraid that we overtreat our patients with the best risk features. We know from the trials of doublets, BTK inhibitors and BCL2 inhibitors, mutated IGHV patients, they achieve UMRD state later and at a much lower rate compared to patients with unmutated IGHV. So why are we overheating our patients? What are we trying to achieve? Does everyone need to become MRD negative to stop treatment? So I think in the next 5 years, I hope the story of MRD evolves as scientifically as possible without rushing into conclusions. I know that time-limited therapy, there is an appetite, rightfully, for time-limited therapy. How best to achieve time-limited therapy? I think the Beijing trial, phase 3 trial of obinutuzumab venetoclax versus Zanu plus sonrotoclax is going to contribute hugely to the field in terms of answering that question. And, we have newer agents that are emerging for our patients with double refractory patients. Pirtobrutinib got approved for patients with CLL who have seen and failed both the covalent BTK inhibitor and BCL2 inhibitor. So those agents inevitably are going to move to earlier lines of therapy. I know, the trial of pirtobrutinib versus ibrutinib in frontline and relapsed refractory has completed accruals, so waiting for the results. And we know that bispecific T-cell engagers are rapidly evolving in the double refractory patient population. I would not be surprised that they move, at least there are going to be trials to investigate their role at an earlier line of therapy. Allogeneic CAR T trials are under investigation currently for relapsed refractory patients. And, historically in CLL, whatever works for relapsed refractory patients, it will move to an earlier line of therapy to see whether in less heavily treated patients, the results are going to be better than using it as a later line of therapy. So to summarize, I am curious to see how time-limited therapy is going to evolve, how MRD is going to evolve, how the new agents are going to make their way to frontline therapy, and the mutation story. Yes, pirtobrutinib versus ibrutinib in frontline, but how does the mutation story evolve? And is that going to be affected by moving, a non-covalent BTK inhibitor and trying it before a covalent BTK inhibitor? So definitely an exciting time, and lots is going to be elucidated in the next 5 years.
And I hope I can have you back to tell us about these new findings as they get elucidated.
Yeah, thank you. I would be honored to join your program.
Thank you very much. I look forward to having you back again.
Same. Thank you, everyone, for your patience.
Thank you.